almost 80 million Americans experience heartburn at least once a month. So the prevalence of actual acid reflux disease is almost anywhere between 18 and 25% in the United States. GERD, or gastroesophageal reflux disease, is the most common GI disorder in the upper GI tract in the United States. Heartburn is the most common symptom of acid reflux, but other symptoms include regurgitation, which is actually acid taste in your mouth, and the feeling of the sour taste in the mouth. Patients should talk to their doctor anytime the frequency of acid reflux is becoming more burdensome. For example, more than 3 or 4 times a week, experiencing persistent heartburn. A lot of times people come in and say they've been chewing things such as Tums or over-the-counter anti-reflux every single day. That's usually a sign that they may have more than just simple heartburn and they have acid reflux disease, and they should see a doctor about that. At least half of the people will get better with the trial of medication if they have acid reflux disease. The goal is to try to get off of the medication or stay on a lower dose of the medication. But if they have to stay on the medication long term, or if they don't get better, then this is when they should seek a specialist care. The specialist tries to assess their symptoms, because sometimes symptoms of acid reflux disease might be mistaken for other problems. For instance, some people will have chest pain and they blame it on acid reflux disease when it's actually cardiac in nature or related to their heart. So this needs to be evaluated. So tests that we offer here, which are a little bit more specialized tests, includes the pH testing, which could be via the endoscopy. It's called a pH Bravo, which is a small capsule that is attached to the esophagus during an endoscopy, and that measures acid reflux every hour on the hour for anywhere between 48 and 96 hours, where the patient carries a monitor and presses on the monitor every time they have a symptom of acid reflux. This helps us determine how bad the acid reflux disease and if their symptoms are really caused by acid reflux disease. Another test we offer is an esophageal manometry test, which is a catheter that goes down through patient's nose to allow to assess how well the esophagus is moving or contracting, and how well the esophagus is functioning, and whether acid reflux has caused any long-term damage to the function of the esophagus. The third test we offer is called the pH impedance test, which is similar to the manometry, a smaller catheter that goes down through the nose and stays in there for 24 hours, which accurately can measure acid and non-acid reflux over 24 hours. Not everyone needs surgery. A lot of patients will respond to medical therapy alone. Usually we try to reduce the dose of medication to the lowest effective dose, and some people can stay on these medications long term with good control of their acid reflux. However, in the small proportion of patients who do need surgery, we have different surgical options.
There are multiple surgical options available, starting with endoscopic techniques. Scarless, we go through the mouth and we can create an anti-reflux mechanism or fundoplication using the scope itself, and it's called TIF, T-I-F. And similarly, in a gradually increasing invasiveness, we can do different procedures like laparoscopic fundoplication or robotic fundoplication, where we use the robot to do the surgical procedure as a tool. LINX is a new technology where basically it's a magnetic sphincter augmentation of the lower esophageal sphincter if the sphincter is not working and every other mechanism is okay, if there is no other mechanical problems. It is a newer technology, although it has been out there for many years now, and we know the outcomes. In our health system, we have performed probably one of the most number of these procedures in this area.
We repair any and all hiatal and paraesophageal hernias, which are defects in the diaphragm that cause the stomach and esophagus to work their way up into the chest, which can really be the main source of reflux and regurgitation in select patients, as well as cause respiratory issues when the stomach is occupying the space that the lungs normally occupy. So it's really a comprehensive offering out here, close working between GI and surgical services, and we try to identify the right patients and the right procedures.
If left untreated, especially in older patients, acid reflux can cause a condition called Barrett's esophagus, which is or can be a precursor of esophageal cancer. Other complications could include usually development of what we call strictures, which is narrowing in the esophagus that causes problem swallowing, and certain times leads to pieces of food being obstructed, needing emergency endoscopy at certain times. Our goal is to properly diagnose and stratify these patients that are referred to us in the Heartburn and Esophageal Center. So if they do not have acid reflux disease, our goal is to diagnose them with the disease that is causing their problem and try to treat that with medical or surgical therapy. And if they do have significant acid reflux disease, our goal is to give them options and optimize the treatment so that they're not experiencing their symptoms, or most importantly, complications from acid reflux.